pandemic? And can we use some of the impetus, some of the energy, and some of the money and resources that are being mobilized for SARS-CoV-2 to not only help us with morbidity and mortality caused by SARS-CoV-2, but for other causes of respiratory infections, other viruses like influenza and RSV. And I think if we can sort of leverage what is happening at the moment to the best need in each of our countries, that may be very useful. So this is to set the scene for you from a South African perspective. This is South Africa. This is our epidemic curve since the beginning of March in 2020, so last year, to very close to last week, the 8th of October. I think this EpiWeek, this report ended the 9th of October in 2021. So that was the end of last week. We've had almost 3 million cases identified in South Africa. And this is the cumulative cases that takes us to the almost 3 million. But more interesting is to look at the 3 waves that we've had. So the first wave was the mix of the wild type and other strains, variants too. Then our second wave, which straddled the end of last year and the beginning of this year, was our beta wave. And then we had our delta wave, which has just ended. You can see here the numbers of cases coming down. And we're just at our nadir at the moment, at this sort of interwave period between 2 waves. And so we're entering that interwave period. And obviously, it's quite nerve-wracking from a surveillance and a sequencing point of view, because it's very important for us to detect early anything that's happening when it goes up. And so this is setting the scene for you for South Africa. And these data are both PCR and antigen positive individuals throughout the country that have tests performed that are then reported to a centralized database. You'll see that later on with sequencing, we need to focus on PCR positive individuals, because there'll be residual specimens left, or swabs with specimens that we can then sequence with antigen that's much more complex, and with the buffers and the additional reagents that antigen testing needs. We've not yet started doing any sequencing from antigen detected individuals. Population-based surveillance sequencing data. This is trying to get data from the whole country. Here you see our 9 provinces of South Africa, and really this is an update looking at more recent. It's trying to look at the 3rd wave for each province. So looking at recent data, we try and update this on a weekly basis to monitor how well are we doing in getting new genomes deposited since the last week. So for each one of these provinces, we look at the new genomes since the last report or the last week. And we try to look at just how representative, if we look at the number of genomes across the whole number of all the cases by province and the number of cases. And so to get a feeling, are we at least getting proportionately enough specimens that are positive to sequence as there are cases? But you can see that there are many, many more cases, and we're less than 1% in our sequence coverage. There are many more cases than we get specimens for sequencing, but we're trying our best. Also very important is to acknowledge that this is covering quite a large distance. We're trying to get geographic representativity, and it's been hard work, and I'll discuss some of the challenges that we've had. You'll see that the percentage testing positive, this is obtained from our national testing report, and it's broken down, and you can access these reports. It shows by region, by lab, and it gives us some information. The percentage testing positive is quite low. That's because we're at this nadir. All the numbers of cases have come down. All the provinces have seen the end of their 3rd wave and are in the so-called or a so-called interwave period. We're trying, for this national surveillance, trying to tell people to, and our efforts are to go to get specimens from multiple geographic regions, to get them from the private and the public sector, to get recent specimens, ideally every week. So really to turn over recent specimens into sequencing on a weekly basis. We give them the labs, and these are all laboratories in the country that are willing to submit to us. We give them the option to send all positive samples, and we'll do the random selection. And for busy labs, and especially at the beginning of the peak of a wave, this is what might happen. They just have no time to select or do any selections for us. They just send us all their positives. Or if they want to, and if they have time to do a random selection, they should select from that week that they're busy, which must be the current week or the most up to the day that they're doing the selection, to number all these positive specimens and to do a 10 to 20% random selection. And the percentage can go up to 20% or higher if the number of cases are low, because then you increase your opportunity to pick up changes by increasing the proportion that is being sent to you. In addition, so that's the routine surveillance that we're trying to do on a national level. In addition, we ask clinicians out there, lab people, laboratorians, technicians, and scientists that hear about cases to keep an eye out for vaccine breakthroughs, for reinfections, and especially send for sequencing if these individuals are hospitalized or clinically severe. In addition, unusual cases with high viral loads, so where the CT value stays low, possible human, animal to human transmission. So when we're trying to explore anything that's happening, and it's almost trying to understand what might happen with zoonoses to increase awareness amongst our clinicians out there that for flu, for influenza, and for these emerging respiratory pathogens, it's an important aspect to keep tabs on, to monitor if someone or a cluster comes in with a history of animal to human transmission. And then if importations happen from countries where there are variants of concern and we can identify. We're not monitoring all borders and sequencing from all borders, and I don't think that is useful, but I do think it is useful for unusual cases, severe cases, and where cases are clearly associated with countries with variants of concern for us to at least attempt getting those specimens and to do some sequencing. And then any clusters of unusual cases. So we're trying to have these testing laboratories, when they have these positives, in the manner that we've tried to describe and to send to these labs, to select their positives and to send them to a whole group of sequencing laboratories throughout the country. These sequencing laboratories will then try and sequence in real time and load the data onto Gizzade. And it's really important that that happens quite quickly. And that's why we are often waiting for Gizzade to release our sequences, so that every week we can monitor what's been loaded and what is the current situation in our country. And you'll see that we mark quite clearly, and this is so that our partners from all over the country who might just have loaded after 9:50, so almost 10 o'clock in the morning on the 8th of October, that they realize that that's why we might have missed their 100 genomes that they loaded. So we carefully document exactly when we downloaded the data so that we can then start looking at those data to see what is happening. And here you'll see the sequences that we have sequenced in South Africa. It's almost 20,000 sequences that we've sequenced overall, but you'll see many more have been sequenced in 2021. And again, just to now highlight, now we're going to start talking about what are the limitations, or what were the challenges for us from an epidemiological point of view and from a genomic monitoring point of view. Here you'll see the epidemic curves that were from cases that were identified in South Africa. And you'll see that we struggled to get on top of identifying and getting specimens for sequencing in the first wave, in the second wave. We're not quite getting the curves right. There's a big, the numbers aren't as high as we should have had them if you think that the wave was almost as big as the third wave. And here we have the third wave already looking much better. This is clearly reflected that we're doing more sequencing in 2021. It took us time to get up and running. And it may be one of the challenges with something that isn't standard, that isn't sustained, that will always happen. We monitor on a weekly basis just how many recent genomes do we have? And you'll see the dark purple here is the color from before May, so before the beginning approximately of our third wave. And then all of these other different colors are each subsequent month, and to try and see how we are doing in representing those months. And you'll notice that for some provinces, and these are provinces where we've had challenges, we've got old sequences, but we don't have as many recent sequences. Even though we could argue that we're getting what we should have sequenced if we look at proportionately the cases by province, but it's still not enough for us to be monitoring recent disease in the country. So this is just looking at the beginning of 2021, and let's just look at the numbers here at the bottom. The top is showing you the proportion. But clearly you can see that here's the end of our third wave. It was predominantly beta. Here you can see beta. We see a little bit of alpha in the light blue. And then in May, sort of week 18, epidemiological week 18, we started to see delta emerging and then becoming the predominant variant in our country. And here's the wave coming down, and us monitoring very carefully this variant that is not yet a variant of interest or a variant of concern. It's simply a variant that has shared mutations. It has mutations from alpha, beta, and delta, and is of concern to us. And we have described it, and we can discuss it a bit later during the discussion, and we're monitoring it very carefully. So here we have, and what I wanted to highlight as well is we're in week 37. As far as the data, updated data. However, currently the week of disease last week ending on the weekend was week 40. So we are approximately 2 to 3 weeks behind, and I'll highlight that a little bit for some other slides. So here we have May, just a little bit more detail, with beta being predominant, about 66%. In June, Delta took over to be the predominant variant nationally, and I'll show you data that breaks it up a little by province or by region. And here for July, August, and September, we have a predominance of Delta with a little bit of C1.2 that we are keeping a careful eye on. You'll notice that even last week, we had no sequences for October, because we're about 2 to 3 weeks behind, and ideally we want to be more solidly 1 to 2 weeks behind in what we're sequencing in the country. So this is looking at, again, just the third wave. So from week 18, on the top panel, you'll see 3 different provinces. At the bottom, it's just the same provinces, just the proportion. Maybe we can just stay on the top panel, looking at the number of cases on the 1 y-axis here in the black line, and then the number of genomes. And I'm just highlighting that even in the third wave, when we look at province data, we can see that there are gaps in our data where we are missing, and we didn't manage to keep on sequencing in a sustained fashion to represent the province and their cases. And in addition, we're not quite managing to get our aspired turnaround times of approximately 2, at most 3 weeks. So we are here in week 40. So we show the data in this way to highlight to ourselves how many weeks we're missing. And here we are in week 36. Ideally, we'd like to have week 38, maybe 1 or 2 sequences in week 39 to tell us what is happening currently in the country. So you'll see, and this continues when we look at the other provinces, another 3 provinces, again, looking at their cases, and then looking at how much sequencing we're doing in those provinces. We still have delays, some provinces more than others. KwaZulu-Natal is doing really well, is at week 37, but here we only have 8 sequences in week 35 for a province called Limpopo. And so we monitor this and discuss this on a weekly basis to try and see where do we have to do more in order to improve our current assessment of the end of the third wave, as well as monitoring the interwave period. And it's really important for us to update the data and get better quality data as we wait in this interwave and NADAR, so that we may hopefully be able to early detect if there are sequences and variants that are occurring in any of these provinces. That here's where we were looking. We were looking from approximately week 18. So that was one of the provinces. This is Eastern Cape. And we've just been looking at these data, trying to highlight where there are gaps for the third wave, as well as more recent gaps. What I wanted to highlight, and this is just talking about the challenges related to sequencing, is, well, how did we do before the third wave? And we're only starting to look for the data here. We're starting in week 1 of 2021, which is sort of when the second wave was coming down. So we were doing good sequencing when the second wave came down, but then we missed a few weeks. And this is what we need to try and work hard on improving, to try and now monitor more recent data. And again, the stories that you'll hear from the different provinces, from all of the different sequencing laboratories, are stories about equipment downtime, staff downtime because people were sick. They'll tell us stories about reagents that they couldn't manage to get. And I think these must be stories that are common to all of our laboratories throughout the continent, that we all struggle to maintain a sustained way of doing surveillance, especially during the hectic and very fraught time of the pandemic. So each of these provinces we've monitored and we've looked and we've seen what we did in the previous wave. We didn't reflect the previous wave as well as we wanted to. For some provinces, we have a bit better data before, and other provinces we're really missing. Again, I think KwaZulu-Natal was very well represented during the end of their second wave, and here they've got good data for the interwave period. But here Limpopo had very little information, and this is a province that is a little bit more outlying. It doesn't have a sequencing center in that province. The specimens need to travel to another sequencing center. And we really have tried hard to improve this. And you can see that compared to the second wave, we're doing a lot better for that region, but we need to monitor and keep an eye on the recent weeks as well. Another province that doesn't have a local sequencing center, where we've done slightly better for the interwave period potentially, but we need to keep up the number of specimens that are sent to us for sequencing. And the Northern Cape, again, another story. I think it was us here at the NICD, specimen downtime, and also communication with the laboratories in that province to bring us specimens, to send us the specimens so that we could sequence them. So I think for all the different provinces and for all the different laboratories, there's been a mix of reasons why things have been challenging, and they will not be unique to us. I think you will all know about those challenges. And I think what I wanted to highlight is that we're trying to learn from those challenges to see, can we improve what we're doing in the next few weeks and months to improve our ability to look for sequences. And I think this is the final. Here's a province that did really well. And the reason why we're wanting to do this, we want to learn from the data that we've gathered up till now. And you'll see here, these are the same 2 years, 2010 and 2020 and 2021. Now, just looking at the proportion, the percentage of beta, delta, and the new variant that we're monitoring, C1.2. And the reason why we wanted to look at the data like this, we wanted to see just how long did it take for the variants to become predominant, become more than 50%, for example. And you'll see for beta last year with the numbers, and here you can look at the bottom, you'll see the total number of specimens that were sequenced successfully, had good enough sequence data that was accepted by GISAID, and so are available on GISAID for those months. And you can see increasing as the wave starts, and you'll see that it took us about 3 months to see it go from 4 to 21%, so only about a quarter to more than 50%. It felt like it went much quicker, but that's partly because we weren't sequencing enough. This is now retrospective data that is filled in the gaps, etc., as well as maybe we weren't monitoring it on as careful weekly basis. But we wanted to now look and see in our country, how long did it take for beta to increase to become predominant? Compare that to delta, also approximately 3 months with some data missing. And you saw that we have those data missing in the early 2021. And that's why the reason we can't go back yet and fill those gaps is because we're prioritizing, or were prioritizing, the third wave. And now we're prioritizing monitoring C1.2. It's been sort of on a low boil. It hasn't quite gotten more than 3%, 4%. We only have about 536 sequences done for the month of September. We have no sequences yet on Gazette for October that are in this report from last week. Hopefully that will change for this week. But this is where we're worrying. So it was described in a paper with Catherine Skippers and Josie Everett leading the NGSA group in summarizing C1.2, and it's available as a preprint. But what it does tell us that this variant that has this mixture of mutations of beta, delta, and alpha is still very much there. And as our numbers have come down, we need to very much be on top of sequencing recent specimens to monitor what might be happening with it. So that is how we're spending our weekly meetings, is looking carefully by province. And these are the provinces now that have most C1.2. Gauteng province, Limpopo, and Free State. But you can see even at a provincial level, it looks like the numbers are small for C1.2 here in purple and not increasing very quickly or exponentially with the data that we have. We need to update our data for some of the provinces, get more sequences for these recent weeks. Hopefully there's not something lying awake for us, lying behind the missing data that we have. But these are the challenges that I'm sure that you have experienced and that we are experiencing in South Africa. So this is looking at our national surveillance, and just try and remember these small numbers of C1.2. As I move to describing what we've identified and been able to identify for Sentinel site surveillance. This is using Sentinel site surveillance that we had in place for pneumonia. Some of you might call it SARI, severe acute respiratory illness, or acute respiratory illness. Some may even do surveillance for lower respiratory tract infection. We are at the moment calling it pneumonia, and you'll see a little bit why in a moment, an influenza-like illness. So these are Sentinel site surveillance systems that we have in place. And the reason we call it Sentinel site is because we only have a few provinces represented. It's 5 provinces of our 9 provinces. And in green, you have the Sentinel sites that we are using in the country. They've been long established. We're trying to make them representative of different parts of the country and different urban, peri-urban, and rural settings. So we try to make it representative, even though it is only Sentinel. It has some drawbacks, and you'll see as we discuss the results that we have from them. Sentinel site surveillance uses a syndromic case definition for ILI and pneumonia. Here's the lower respiratory tract case definition. We changed it in March last year to include suspected COVID, and we did the same for ILI. We wanted to expand our system, our Sentinel site system that we had in place for influenza. We were also testing for RSV on that system. We expanded as the pandemic started coming into the country and there was community transmission. We went to the Sentinel surveillance sites and updated our syndromic case definition to include SARS-CoV-2. And we have learned before that expanding the case definition, not having a strict SARI case definition that is acute, for example, but rather has acute or chronic, includes some other aspects that may help from a clinical perspective to increase our ability to detect RSV, so other pathogens other than flu, and now to detect SARS-CoV-2. You'll see that this is the epidemic curve from our outpatients, our ILI surveillance sites in total, and this is the inpatient SARI and pneumonia epidemic curve of SARS-CoV-2. So this is when we identified cases, and then the percentage positive of SARI. So you'll see here just the 2 waves, the first wave in South Africa and the second wave. And you can see that our surveillance sites did quite well in documenting the trends of the two waves. So we knew that the trends of SARS-CoV circulation among outpatients and inpatients in the Sentinel sites mirrored those of the national surveillance. So that was a good aspect of containing and maintaining surveillance for SARS-CoV-2 within these sites, and for us to now look retrospectively, well, what can we do going forward, and how well would these sites manage to document the outbreak, the pandemic, and as the pandemic becomes an endemic disease in our country. If you have a look, this is one of the incredible strengths of our Sentinel site surveillance and yours in those countries that are running these, is that you have historic data. So here, for ILI, the outpatient, for pneumonia, the inpatient surveillance, you'll see in gray, this is RSV, in blue is influenza, the seasonal increases of those two pathogens in both the outpatient and the inpatient surveillance systems. And here is 2020, when in fact the only thing that stayed was positive were RSV, but they broke away from their classic early in the year seasonality. There was an unusual epidemiology for SARS, for RSV. And the strength is that we've got the older data, the previous years to compare to, and in fact, very little influenza detection, with only now recently influenza detection in our surveillance sites. And overlaid over this is now SARS-CoV-2. And you can see how we managed to then document the first and the second wave and the beginning of the third wave in this figure of COVID-19 in these two settings. And so this is the biggest strength, is really having both historical data and having ongoing data for the disease, as well as then in the future for sequencing and characterization of flu, RSV, and SARS-CoV-2, in addition to be able to see the interplay and the differences between these pathogens in our setting in the season. And I think this is going to be very interesting going forward, is looking at influenza, as influenza might change, or how does it work with SARS-CoV-2, how does it work with RSV in 2020, the end of 2021, and then going into 2022. Here we have data, the same epi curve, but now showing you our sequenced results. And you'll see that for outpatients, we're able to show the non-alpha beta delta, so the non-variant causing disease in the beginning of the epidemic, and then being taken over by beta and by delta. And this has also been possible for us to do when we look at our pneumonia surveillance. And this is a mixture of using a PCR to look at variants, because we had to catch up. Again, our sequencing wasn't in place. It was a new pathogen. We had to catch up the older data, and we're busy doing sequencing on some of the older data. But more recently, we're now on track to sequence each week as we identify the cases through our Sentinel site surveillance. We send for sequencing and we get up-to-date data for what variant is causing disease in our surveillance sites. I'd like to highlight for you that C1.2, here it is in black, should be easily noticeable, but the numbers are really small. You can see that because it is only at Sentinel sites, the numbers are much, much less of what we're getting for sequencing. We're only detecting 1 or 2 C1.2s, very few numbers here. They are there, so we would have been able to pick it up, but it would have been slightly less comforting. And I really do believe that the national surveillance is giving us a lot of additional resolution and a lot more to go on at the moment during our pandemic response. But here we have the sequencing data for those two surveillance platforms. And very importantly, because they are established platforms, the specimens are taken from a syndromic point of view. We can say this syndrome is detected, we are taking a specimen, it's done in a systematic way. We're collecting additional data. You'll see age groups, and I'm only showing you some of the additional clinical data that we collect on our surveillance platforms. We are able to start to look at the variants. And here we're looking at, were they associated with you being more likely to be admitted as an outpatient or as an inpatient? And you'll see that there's some hint of slightly increased odds, adjusted odds ratio for the Delta variant. So the Delta variant in the setting and these preliminary analysis seem to be slightly more associated with hospitalization if compared to the non-alpha beta Delta. So that would be the first wave in our setting. And so this is one of the strengths of using an established or building up an established, more resource intensive for only a few Sentinel sites and getting additional epidemiological and clinical data. In addition to looking at what is associated with being admitted and being an outpatient, we also looked at variance and case fatality ratio to see if any of the variants were associated with an increased case fatality ratio. And you'll see that there is a small increase of maybe an adjusted odds ratio tending towards 2, but it's not yet significant and the numbers are small, but it does allow us to start to do these types of analyses when we look at our surveillance sites. So the considerations for South Africa, just in summary, is we're looking at what are the strengths. Well, the larger numbers if you're doing national surveillance, it's really good in detecting clusters because you're looking throughout the whole country. And it has been sensitive. It's been proven to be sensitive for the detection of emerging variants in our country. You cannot influence specimen taking practices. So we're looking at, well, the clinical threshold of when do doctors and nurses take specimens. That is changing as the pandemic changes. It is definitely changing in South Africa. We can't change that. And so our specimens that we receive will reflect, well, what is being tested for. And we won't be able to change when antigens are being mobilized in different communities. And so that's something definitely to keep an eye out as a limitation and as we interpret our data. There's very poor linkage. We have very limited metadata from all of these specimens. At most, we have age, we have specimen collection date, and we have location. So that's one of the limitations, and it is expensive, even just because of the numbers and trying to do this large throughput of sequencing, it is expensive. What are the strengths for Sentinel surveillance? It might be more sustainable, but it's not inexpensive because it needs additional resources at the Sentinel sites, but it does control specimen taking practices. It has a syndromic case definition, and the diagnostic testing is controlled by you who are running the surveillance program. It has clearly better linkage, and therefore you're able to do more with the data to look at your variants, to look at the genotype results, and you can link to other pathogens and you can explore interactions. As I was saying, we want to monitor in South Africa what is going to happen with influenza and RSV going forward. The limitations are that there's small numbers. You saw us struggling to identify cases of C1.2 if we look at it overall. Yes, it is there, but you'd have to have a very low threshold for action when you have small numbers like that, and it has limited ability to detect clusters and outbreaks. I think very importantly, you need to how the objectives of SARS-CoV sequencing will change. The objectives will not remain the same. They cannot remain the same as we move into what might be seasonal increases and decreases, rather than looking at waves. Might be that we want to just document the beginning and the end of a seasonal SARS-CoV-2. Will it be similar to flu? The reasons for doing sequencing on SARS-CoV-2? And do we need to help in the future in variants, understanding the variants that are circulating and vaccine formulations to assist with vaccine formulations? Will there be other new objectives? And just because it's happening at this moment, there is at the moment, I was at the session just before I joined you here, the second WHO global e-consultation looking at GIZRS Plus, so using the influenza system, looking at whether we could add SARS-CoV-2. How can we work together with all the laboratories that are doing such good work in identifying COVID-19 disease? Can we sort of look at whether NICs, the National Influenza Centers, or laboratories that are reporting to GIZRS are already running surveillance programs? How can we integrate and leverage their experience? And there was a laboratory session just now, and there's an epidemiological session, a parallel session where they're discussing some of these issues. And I'm hoping that colleagues of those that are attending this webinar, we'll be able to go back to other colleagues who are attending this meeting, and you'll be able to talk about what options you have available for the future. There are many people that are involved in our sequencing NGSA network, many more people than are depicted here, and many people that are sending us specimens from throughout the country, from private and public labs who have given us support, given us funding, making it possible for us to document what we've documented so far and hopefully make improvements going forward. In addition to acknowledge this, our surveillance site. So the surveillance site, we are going to try and see whether this might be an option as a platform for ongoing sequencing from an epidemiological and a genotypic point of view to monitor the epidemic in South Africa. And so thank you for your attention, and hopefully I've left enough time for us to have a discussion. Thank you very much. Over.
Yes, thank you very much, Professor von Gottberg, for that very, very insightful presentation. And I'm going to be asking the questions in the order in which they arrived in the chat box and in the question and answer panel. So I think, so the first question was from Fentabil, and he was asking, what are the key factors triggering the resurgence in South Africa?
I think it's multifactorial. I think the resurgence, each time we saw the increase, there was a new variant. There may have been some immune escape. Delta had increased transmissibility. There were also a reduction in restrictions. We had, as the wave comes down, and exactly the same has happened now in our interwave period. As the number of cases come down, the government, everyone takes a sigh of relief and says, please, let's get to close to normal as possible. And exactly that is happening. We had our first soccer match in a stadium with live attendance just a day or two ago. And none of them are solely responsible for increases in cases, but I think they all work together to then result in a new wave. And we need to see what has changed and how is immunity, how are the immune gaps in our population going to allow for another wave, and how big that wave might be going forward. Over.
Thank you very much. And for the second question, so Dr. Chelea from Cameroon wishes to know if there were any cases of suspected vaccine breakthroughs in South Africa.
Yes, in fact, a lot. And not some of them are proven vaccine breakthroughs. So, and I have to acknowledge, I think I might be. Exactly. I had the J&J vaccine, and then several weeks later, I became sick with COVID-19. So, with proven SARS-CoV-2. So, none of the vaccines are 100%. We don't expect there to be no breakthroughs. We know that there will be vaccine breakthroughs. It's also the reason why we are saying not to sequence all vaccine breakthroughs, but rather to sequence the ones that are admitted or have severe disease, and to have a routine ticking over monitoring of vaccine breakthroughs from a genotypic point of view. Over.
Thank you for that. And the next question is from Tamrat. He asking, how can we identify the exact cutoff point for variant shift from one type to another? The cutoff point for variant shift.
I think we will know that when we've had a few more waves and when we have a few more variants. It's like we have two data points in South Africa, at least, a beta and a delta data point. And we need to see, and the data points, the cutoffs are difficult also to predict because things are different in those two waves at that time, because the immunity in the population was different, vaccination coverage is different. And so there are different epidemiological and population environmental factors that influence what is happening from a next wave, and the transmissibility is also different. So I think you're asking exactly the right questions. There are no simple answers. And I think we need to deal with that uncertainty. And we're trying to monitor in South Africa by looking at what happened in the last two waves and then overlaying the new variant to understand what we can do with that going forward. Over.
Yes, thank you very much for that. And the next question is from Aitenu. To what extent should surveillance data be considered as part of a response system in South Africa?
It needs to be integral. So our cases, so the surveillance of cases is every day is used, we monitor it and it's reported every single day. Then we summarize it every single week. And that is used by our government, by our provinces to make decisions about where are they in the restrictions, what should they be doing about recommending funerals, gatherings. It's used all the time to assist us in understanding how much we also need to prepare hospitals, ICU beds, oxygen to check what's going on. So it's integral. And that surveillance is the national surveillance for the pandemic. And I think that's important. You need to do that when a pandemic is new and it's not into its second or third year. But slowly we might have to do something slightly less intensive to continue to monitor COVID-19 going forward. Over.
Okay. Thank you. And then we've got Dr. Khalid Abubakar asking, I think there's two questions. First, did genomic sequencing provide evidence of ongoing mutations of the variant of concern or variant of interest? That's the first question. And then the second question is, how can environmental sample testing for COVID-19 provide complementary support for predictions of ongoing outbreaks in, I think, settings for low testing in some countries?
Great, very good, all very good questions. So the variant, I think beta, we identified that it was in South Africa, and we did the NGSA, the whole team of all the sequencers, all the labs did very well to report that, and I think that did a good job, and it was exactly looking at the mutations and deciding these mutations, this constellation of mutations are worrying. And then for Delta, we were able to detect the importation of Delta into our country and then the spread into community transmission. For C1.2, at the moment, it's a variant that we're not concerned about in the same way yet, but we want to monitor carefully. And it looks like that all C1.2s are travelers. If they are identified in other countries, they were travelers from South Africa or had links to travelers from South Africa. So at the moment, there's great strength in monitoring the mutations and the variants if you have real-time data. And I think that's our biggest challenge, is to make those data meaningfully real-time. Environmental sampling, I think, is very good where testing is not happening and where you just want to pick up an increase. And we've presented on the NICD webpage, there are data showing the increase in environmental sampling quantity of SARS-CoV-2. So you use a quantitative measure as the cases increase. So I'm not too sure how much earlier it'll detect it, but if you have no case data, it may be there to help you to understand what is happening in that community. Over.
Okay, thank you for that. And then we've got Harris asking, has there been any reported case of human to animal SARS-CoV-2 transmission in South Africa? Human to animal transmission.
Yes, there have been, I think, and I don't know about all the stories, but we've had anecdotal reports and they're being described by experts, all the experts in the country. But yes, in fact, in zoos, and the ones that come to mind immediately as you ask the question, zookeepers or zoo vets and carers, then a lion becoming sick with a respiratory infection, testing positive, most likely, and the source of infection was most likely from the individual looking after the animal, and then the animal becoming sick. But they are anecdotal reports, they are rare, and they were as a result of breakdown in non-pharmaceutical interventions where looking after animals, especially at such close quarters and for such long, prolonged periods of time, we should be wearing and having NPIs in place. Over.
Thank you, thank you. And then Hanan wants to know, did you observe any mixed infections in your population samples, having more than one variant?
We've had a hint of us thinking that there were two variants, and we're exploring those a bit more carefully. We don't do it in as much detail in the surveillance, in our routine surveillance, the ones that I've described now. We're doing that a bit more carefully in our research projects, now household transmission, and in 1 or 2 shedding studies and case ascertained household transmission studies. So we are investigating that. Yes, I think there are data to show that potentially if we look carefully enough, we may detect mixed infections. And definitely what we've detected is 2 different variants coming into our household. But they aren't the premise of the important bits of information for a public health response. I think that's getting into the interesting research questions. And you're right, they are very interesting. Over.
Okay, thanks for that. And then we've got Ayodele asking, were the Sentinel site detections for COVID-19 by PCR? Number 2, how would you explain the low detection number of influenza during the pandemic in comparison to previous years?
So yes, we did use a PCR for variant, and there it's the one we used was a commercially available one, but there are lots of different PCRs available to detect variants. There are some limitations to that, and especially if there's a new variant, like there's nothing that helps us understand what is happening with C1.2. The second question was about, influenza and the low detection. We think it's as a result of multiple factors, the reduced travel, so less importation from other countries, from north to south, etc. But also very important, mask wearing, social distancing, other non-pharmaceutical interventions, because we've seen reductions in other respiratory pathogens. So bacterial pathogens have reduced during the pandemic, and that's been shown quite nicely and been published. There've been, and the fact that some of these reductions can't be mirrored for fecal-oral bacteria. So where surveillance is ongoing in countries for something like Group B strep, they've not shown similar reduction. So we think it's as a result of research as a part.
Okay, thank you for that. And then we've got Awa asking, what do you think about using malaria Sentinel sites for SARS-CoV-2 genomic surveillance?
I think if there's infrastructure and resources to consider those clinics, definitely. Malaria is different. The presentation of malaria would be different. So you need to start with the new syndrome and how you're going to detect individuals. And definitely if that's the only place and there's been no respiratory surveillance in place, definitely consider to make it a multi-pathogen respiratory surveillance system. But I think you all need to think of where do you have options? Where is it sustainable and where is it possible? And to try it. It may not work. It may not work for several years, for several months. But what you need to do is stay strong and try what does work in the end in your countries to make sure that you have some system in place that prepares you for the next pandemic and for describing these diseases in our countries at the moment.
Thanks for that. And then we've got Eric asking that we have seen increased hospitalization in pregnant women in Kenya, especially following the outbreak of the Delta variant. Have your surveillance team made similar observations in South Africa?
We've definitely seen the hospitalizations. The pregnant woman, we have too few. So again, it comes to then the limitation of our surveillance side. But we do know that nationally, gynecologists and obstetricians who are looking after pregnant women are talking about this. And we know internationally that the data point to these increased hospitalizations in pregnant women. So I think you're right, you're picking up the right red flags. And our Sentinel surveillance hasn't been able to do that definitively yet, maybe in the future, but other data are coming together that show exactly the same.
And then a question from Kison. Do you keeping data such as mortality standardized in GZAID or other databases a challenge? And how are you addressing this? We
definitely are challenged by it. We're trying, GZAID, we try to keep to a limit of what is important for the global response, as well as not too much information that would break the anonymity of our individuals, the people that are entrusting us with their specimens and their data. So GZAID is a bit of a mixture of information, but you're absolutely right. It's very difficult sometimes to get accurate age, at least age group or specimen collection date, etc. And then we have our own database that has additional metadata. And that we're trying to now have one database looking at the national data that has additional information. And I cannot tell you how much of a challenge it's been and how much we're working. And I'm happy for anyone who would like to chat about some of these challenges and experiences. We can share offline by email, etc. But you're right, it's an incredibly big challenge, and we still don't have what we are considering a functional database that helps us on a weekly basis to understand what is going on.
Okay, I think, and in the interest of time, thanks so much for that. We've got Richard Mwesigwa asking, what strategy can be used by resource-limited settings interested in genomic sequencing for COVID-19 epidemiology, surveillance, and response?
I think to work with the biggest hospital, a big clinic, to start with some syndromic system, because if you do just a little bit of from everywhere, I don't know how sustained and how representative it'll be. But if you can do something sustainable that has additional clinical data from a hospital for inpatients and severe disease for ILI, for outpatient disease, and then to sequence those. So to start, I think we had to acknowledge, you will see that early on in the pandemic, we weren't doing a great job. We didn't manage to do much at the beginning. We had to improve each time. We're only now starting to get something which reflects a slightly better reflection of the true epidemic in our country. So I think start small is my advice. Start with other colleagues and start with clinicians as well as other laboratorians so that you can really leverage many diseases, multiple pathogens, and other colleagues and other initiatives. Like if malaria has a good initiative and is willing to help at least give some of time of their staff, that's the way to start. So I think use imaginative ways of starting surveillance, genomic surveillance in your country.
Okay, thank you very much, Professor Annie, for that very wonderful presentations. Very good comments coming over. But I think because of, in the interest of time, we're on the top of the hour, we'll have to probably take some of the excellent questions offline. So on behalf of the Africa CDC and the Africa PGI, I take this opportunity to thank all of you for joining the session and for your participation. Please join us for the next PGI webinar to be on the 27th of October, and you are going to circulate the details soon. Thank you all very much, and do have a great rest of the day. Thank you
all.
And goodbye.
Thank you. Cheers.
Bye-bye.
Bye.
Bye.